Welcome to Physio Standard, a global podcast for physiotherapists who want to lead, not follow. Today we are joined by Sid Anandkumar, a physiotherapist based in British Columbia, Canada. He specializes in chronic pain, male pelvic floor physiotherapy, and TMJ and orofacial pain. He has also given a TED Talk titled Low Back Pain Myths versus Facts in 2018 and is the recipient of the 2019 Physiotherapy Association of British Columbia Award for Excellence for Clinical Contribution. Sid has published many research articles in international peer reviewed journals and is the author of the book Fixing Jaw Pain. He's also an educator and teaches a workshop titled Temporomandibular Joint Disorders Evaluation and Management for Rehab Professionals. So, welcome to the podcast, Sid. How are you doing today?
I'm doing fantastic. Thank you so much for having me, Srividya, on your show.
So, I did introduce you, but I also wanted you to talk a little bit about your work and your involvement with TMG and orofacial pain.
My association with TMJ goes right back to when I was a new grad. It was in 2010. I still remember the one of the very first few patients who walked in to see me. He had complaints of jaw pain, and in an undergrad, we hadn't got much training in the field of like temporomandibular disorders and in the jaw joint. I still remember him very well because the next door to our clinic, like we had a psychologist, who was sort of dealing with people, and she had referred him to us, and he came crying, because his wife was going to divorce him. Right. So this was the situation. And I asked him why, as to I went into the history. He basically told me that he couldn't be intimate with her because of severe facial pain. And it was causing a strain in their relationship. And this was a curve ball for me because this was the least thing I was prepared for. That's how actually I got into this world. I did successfully end up treating him through consulting with colleagues and books. And I think in 2010, YouTube was like the Wild West. It is not the corporate overlord or corporate structure it is today. With some difficulty, I did manage treating him. And I think that's what got me more interested. And there's one more patient I would never forget because this just happened, like back to back all of a sudden. I don't know if it was destiny or, something just pushing me in this field. The second person was actually a small time actor. He had to sing, act, and do like drama on stage. And he said he couldn't sing. He couldn't play, the flute and or talk, deliver his dialogue. So it is very interesting. I think I was very fascinated. And I think those are the cases you remember because you're so fresh. You're raring to go, like test your clinical skills. You're so excited as a new grad. And I think it's quite overwhelming at that time, looking back. So that's how I got into treating orofacial pain, getting more interested in the jaw.
And now it's become like a
It's been quite.
specialization.
I would say it's more like a clinical interest. Yeah, I do love treating the face and the jaw. So it's a very fascinating joint. It has more to it than what many people even realize because we just take it for granted.
You're right. So, for physiotherapists who may not treat TMJs, TMDs that often or at all, what would you say about TMJ as an introduction, or why would you say that it's such a unique joint?
It's very unique because think about it. The TMJ actually starts developing when you are almost 7 to 8 weeks of intrauterine life. It starts forming even when you are in fetal life. Like by almost 20 weeks, the joint is formed. And the reason is because we need to sustain life. I mean, like, what do babies do? They need to drink milk. And to drink milk, they need to suck, they need to swallow, right? And that's all the function of the jaw joint. And it continues to develop all the way up to the age of 20 to 25 years of age. That's just to show that, like genetics is one part of it, but the biomechanical forces are a huge component to which the joint is being influenced by and, which influences the functioning of the joint. So I think it's very fascinating to just see the timeline as to, how it goes and how it develops into, that it is important for all vital functions, talking, sucking, chewing, swallowing, things we just do it, on a day-to-day basis, but we don't pay much attention to it until something goes wrong. So it's very fascinating with the presentation.
Okay.
Also, what not a lot of PTs are aware of is that it overlaps with many clinical conditions. For example, you'd be surprised to know that almost more than 50% of people who have TMDs have migraines. More than 60% who present with TMDs also have chronic back pain, right? And almost 20% of people end up with severe depression, about IBS, like irritable bowel syndrome, gut issues, and almost 60% of, again, 50 to 60% of people with TMDs have stomach pain. So there's a very fascinating overlap with other conditions, but also on its own, it's kind of unique. So there's a lot of overlapping mechanisms which come into play. So I think it's very fascinating for physios because we treat back pain all the time, or we treat migraines, headaches, but rarely do we even associate that it would be coming from the jaw.
Yeah, I did not realize that it's related to IBS and low back pain.
Yes.
I mean, I would have guessed cervical or thoracic pain.
True. Because of, again, if you go back, it's to do with there's a lot of overlap due to the shared mechanisms of pain
Okay.
and the sensitization in the whole body. And now there's a huge focus on the gut brain axis.
Right.
And how the gut influences, the systemic inflammation. So yes, I think a TMJ it has an overlap. Not to say that is causing this. I think just to be clear, it is just an overlap, and it just exists in addition to that. But it's interesting to note that. I feel these are things which physios miss out on, and we should focus more on these overlaps. Simple things, in clinical exam, just by asking questions. And it's very fascinating to get the answers from patients.
Okay. So if somebody comes in with TMJ issues, what are some signs and symptoms that physiotherapists should watch out for?
Commonly, we question about pain, because that's one of the main focus areas for us. But what not a lot of people realize is pain could be on the side of your face, right? No one's going to come and tell you that I'm having jaw pain, They're going to be like, I've got this vague pain, maybe in the side of my face, maybe in the side of the lower half of my face. It could be behind your ears. It could be in front of your ears. Some people present with pain under the throat, and a lot of people have pain inside the ears. You'll be surprised to know that a lot of patients would have ear pain, but completely ruled out of infections. But they still get antibiotics to get treated, and the ear pain doesn't go away. They're not able to find any structural cause for the otological pain, what they're experiencing. So which could technically be referred from your temporomandibular joint. So I think those are some symptoms of pain which you need to watch out for. The second thing is joint range of motion. This is something basic. You're going to ask them, like, do you have difficulty in opening or closing your mouth? Difficulty or any limitation in your jaw range. So these are two common things which, as physios, we ask for, and how it's affecting your function, right? With chewing, talking, swallowing, eating, and stuff. The other uncommon symptoms, but it's actually related with the jaw joint or the TMJ, is headaches. And I think we talked about it in the previous question that migraines have a huge overlap with your temporomandibular disorders, but also are cervicogenic headaches and tension headaches. So migraines, tension headaches, and cervicogenic headaches have a huge overlap with your temporomandibular disorders. So right now, the thought process is we are not looking at it as separately as primary and secondary headaches, but just headaches with one continuum, but with different presentations. A lot of people with migraine also have a tension component. A lot of people with tension headaches have also migraines and vice versa. So, same thing with cervicogenic headaches, right? So there's a huge overlap between all the four. So eventually, when you have a patient with migraines, I think it's very important not to box them in one category. And you want to start questioning them about other symptoms which they might be having. And it's known for a fact that a lot of people with migraines have a lot of tenderness over the neck and temporomandibular joint muscles. I think that's something which we need to focus more clinically with headaches. Headaches are huge, which is often missed or mistreated. And the problem when these symptoms are not diagnosed properly and when they are not treated for a while is that it leads to nociplastic pain, right? So there's a lot of central sensitization and peripheral sensitization symptoms which happen. In fact, there was a school study which was done, I believe, in 2009, where they found reduced pain pressure threshold in the tibialis anterior, which absolutely has no connection with your jaw pain. But in patients with chronic jaw pain, they found reduced pain pressure threshold in the shin muscles. To just prove that there's actual sensitization process happening in the whole body. So I would look for headaches and pains clicking of your jaw is another important symptom which we need to screen for. Like, do you notice your jaw making any noises? When you open your mouth, it's a very simple subjective question we can ask patients. Does it lock? Does it disturb your function? Have you had any difficulty opening your mouth? So these are all questions which sort of directs us in that line. But also what physios must be aware is almost 30% of the population have asymptomatic clicking, to 30%, 30 to 50%, some studies, but I would say most of the studies say it's about 30%. You just can't question them about one symptom, but you got to again ask them to find the relevance. You got to note the other subjective history of pain and how it's affecting their function. Sometimes when it's symptomatic, it can affect the way they talk, the way they are yawning. Sometimes some people who are professional wind instrument players, like for example if they play flute or trumpets or anything like that, where they got to use their mouth a lot, or even people who speak a lot, like public speaking, for example, they often have issues with the TMJ. Some of the uncommon symptoms, which again a lot of physios need to know, is that issues with the temporomandibular joint can cause plugging of your ears. It can cause reduced hearing on one of the sides where all the hearing tests are actually normal. It can cause tinnitus, a ringing sensation in the ears, which is again somatosensory. It is coming actually from the jaw or from the neck, which can be treated. Vertigo and dizziness is another common symptom, which they sort of present with it. And so there's a lot of overlapping symptoms, which we need to screen for apart from pain. So vertigo and dizziness are some of the symptoms. So I think it's good to know all these subjective questions you want to ask in history rather than just focusing on pain. Pain is one component, but there are other things which would help in the manifestation.
So you broke it down into common symptoms and then uncommon symptoms as well. What we commonly see in terms of pain and function, and then uncommonly what is seen in terms of headaches and loss of hearing or lesser hearing, plugging of ears, vertigo and dizziness as well, along some of the uncommon symptoms to watch out for when a person presents with TMJ pain or an orofacial pain.
Yes. And also the other uncommon symptoms of pain would be pain in the tooth, right? So all the dental causes of pain have been ruled out, but they still got pain in the molars or the premolars, which could be referred again from the temporomandibular joint muscles. Sometimes people have pain in the sinuses, like a sinusitis like pain, but it's been checked out and they actually have no issues with the sinus, but still it's all a referred pain. Because one of the things to understand is the lateral pterygoids and the medial pterygoids, they all come from the sphenoid bone, which is very close to these zones over here internally. So there's a lot of stuff happening, which can manifest that way. Or a deep earache, which I think I mentioned. So
okay, why are there so many overlapping symptoms when it comes to TMJ?
Excellent question. So one of the things is we have something known as the trigeminal cerviconucleus, which is on the lower end of your brainstem. Basically, it extends from your medulla and goes to your upper cervical area. So you have your nerve roots of C1, C2, and C3, which converge on that part. You also have your cranial nerves of 5, 7, 9, and 10, which converge in those same neurons. So it's a neuronal complex which is present. So that is one of the mechanisms by which any dysfunction in those zones can actually affect your ears and your face. And now, as we know, the trigeminal nerve has three branches. It has like the V1, V2, V3, right? So it has the ophthalmic, maxillary, and the mandibular branches. And if you look at the mandibular branches, we have the deep temporal and the masseteric nerve, which supplies the temporalis and the masseter. But we also have the auriculotemporal nerve. So auriculotemporal nerve is a purely sensory nerve, which supplies your ear and behind the ears. So that could be again one of the causes for the referral, leading to that. But also the inner ear has a direct connection with the jaw. So this has been proven by a guy called Pinto. He called it the Pinto's ligament or the discomalleolar ligament, which directly connects. It's not described in anatomy textbooks, actually. So this is just fairly recent, I would say, so in research, where the disc has a ligament which connects it to the malleus, the inner ear, right? So any sort of dysfunction over there can actually affect the mechanism of sound transmission. There's a huge, link between that. So that's why people hear all those crackling noises and pain and, like a plugging sensation what they get. So these are all the different mechanisms which are thought to, occur with each other. And same thing for dizziness as well, because there's a lot of tension in your suboccipital muscles, which directly impacts the trigeminal cerviconucleus, which in turn, mediates vertigo, dizziness like symptoms. But also there are other muscles like your sternocleidomastoid and your trapezius, which in turn, they by themselves can cause tinnitus and symptoms of dizziness, when they are in a dysfunction. Now, I know trigger points are quite a controversial topic, so I'm not going to get into what is a trigger point and all that stuff. The point I'm just trying to make is, you push on that muscle, and if it reproduces the tinnitus, I'm just going to treat it as a clinician, right? So I'm not going to get into the debate
Does it exist?
of whether it's an exactly exist or not. Like for me, the clinical utility of that is I just want to make sure that the patient benefits from some treatment. So yes, and also you want to know that the tongue has a very, very intimate connection with the jaw. So, for example, you have the stylohyoid ligament, which comes from the styloid process, and it attaches to the hyoid, and it provides a connection for your styloglossus, which is one of the tongue muscles. Actually, you can just try it out now. Put your tongue out. It's going to look funny in the video, but just put your tongue out, and just point your tongue straight out to, to the front of the screen, and you would notice something happening to your jaw. You'll notice a lot of tension happening in the throat and in the jaw. So that's why it's the tongue is huge, and when it's connected with the jaw. So
Experienced that. I had a dental procedure yesterday. I did experience
we
that
had a lot of
tension.
symptoms. And it's interesting you mentioned that because this is a part of history which a lot of us forget. Have you had any dental surgeries before or any dental procedures before? It's a simple question we can ask patient. It opens a whole avenue for us to approach, see what dysfunctions, because some of those procedures take an hour. And imagine having your mouth open for an hour. And I think when that's happening repetitively, it's going to cause some trauma to the structures.
True. I do remember actually that I had a lateral shift after my first dental procedure, which was a root canal on this side. And yesterday, after having kept my mouth open on the right side for a long time, I did have some tension and difficulty closing and opening my mouth after a while. That's also one of the questions, like you said, that needs to be asked?
Absolutely, asked as physios. And some of these things are sometimes transient. They come and they go off in a few days, which is fine. And that's the amazing statistic, like almost 50 to 75% of us have had one symptom of temporomandibular disorder in our lifetime. Eventually, we would have had it, we would have experienced some tension in our jaw, some headache, or, like as you mentioned, you had a dental procedure and you just noticed your jaw moves a little funny, it's tracking funny. It's normal. Sometimes it's transient, but it becomes an issue when it doesn't go away. And there are other things which contribute or make the condition worse. And that's when you want to start, paying attention to it.
Right. Considering that this should be the joint that gets used the most during our days, right? While talking,
And you are correct with that statistic. So, do you know? So, you were aware of how many times we use the joint in a day? Like,
I don't know.
it's 1,500 to 2,000 times a day we move our joint. Okay,
That's
just
a lot.
for on an average. Yeah. So that's just what the stat says, and that just excludes parafunctional habits. Now, what parafunctional habits are repetitive orofacial habits which causes strain to the joint? For example, constantly licking your lips, or if you're trying to move your tongue against your cheek, biting your lips, biting your cheek, biting on your nails. So actually, one study showed out of I think more than 200 or 250 adolescents, biting on 50% of them were biting on their nails, chewing gum, repetitively chewing gum, chewing on ice. These are all parafunctional habits, clenching, right? Because some people, that's one of the mechanisms by which they cope with stress is through clench the jaw. Bruxism, where they clench and they move their jaw back and forth, repetitive grinding. So all these parafunctional habits increases the pressure on the jaw joint. Now, normally, if you look at the PSI levels, which is the pounds per square inch, normally when you eat food, when you say, for example, eat a carrot or when you're eating something, it's about 40 to 70 PSI and it's hard. When you have parafunctional habits, it goes up to 400 to 500 PSI. It's almost double, triple, four, five times, the amount of pressure the forces you're applying. And don't get me wrong, the jaw joint is super strong. It can exert forces up to 265 to 270 pounds, which is almost the weight of a refrigerator. Correct. It's super strong, But when the joint is abused or overused, and all of this happens unconsciously, there's so many things contributing to it. Yes, you are looking for trouble. So that's what slowly starts manifesting as some of these pain symptoms,
True.
which can be quite unconscious. A lot of people are not aware of this. And look, and we are in the social media era. Think about it, like how many times people pout their lips or make funny faces just to look, sexy or attractive on screen. And you think about it, when it happens repetitively and you're using your mouths and lips and your whole face so much, then it just sort of becomes like a repetitive trauma.
Yeah, I get that. Said apart from the ones that you already mentioned, like having dental treatments and parafunctions that exist, what are the other causes of TMJ and orofacial pain?
So broadly, when we examine patient, we can divide them into different categories, and one of them is micro trauma. So that is what we talked about in terms of parafunction. When they
Right.
have bruxism and when they clench their teeth, licking on their lips, and so on. Some of the other parafunctions, which again we need to be more aware of, is mouth breathing. Because when you're breathing through your mouth, or when you're snoring, for example, people with obstructive sleep apnea, you are using a lot of your jaw muscles, your facial muscles. And also, there is something known as sleep bruxism, which we need to be aware of. Often, when we sleep at night, because the brain detects a threat that the jaw is out of place, so it starts contracting those muscles to keep the airway physically open in an
Mm.
attempt to keep it open because all these soft tissue structures are collapsing, which can in turn cause pain. A lot of people with sleep apnea wake up early morning with a clenched jaw. There are other causes, that's a whole new topic because the sleep apnea, for example, causes lack of oxygen to the brain, and that sort of sensitizes your whole sympathetic nervous system. So there's a lot of overdrive, overstimulation, and all of this happens, with reduced, what happens in the REM sleep, for us when bruxism happens. So one of that is micro trauma. The second cause is macro trauma, which again, one of the most common things in North America here is whiplash injuries from high speed motor vehicle accidents. And what you mentioned about iatrogenic dental procedures where your mouth is open for a long period of time. Or macro trauma can also be from a sporting injury. So you're playing cricket and someone hit the ball hard in your face. And one of the less talked about topic, but which is also a taboo for some patients, is domestic abuse. Right? When people are being slapped or forced to perform certain things which they're not willing to do. And that's why the psychosocial component is a huge role to play in this, as to how
Mm.
this can further all the stress and the anxiety which people carry, which is going to keep contracting those muscles, and which they have a huge role to play, in giving TMD symptoms. You also have systemic issues which you need to be aware of and screen for. So a lot of people with rheumatoid arthritis, for example, can also
Mm.
present with jaw pain and with pain in the TMD. So I'm just using jaw pain and TMD interchangeably here, but it's actually
Right.
TMD what I'm talking about. With the psoriatic arthritis, they have a history of psoriasis. You want to screen for these one things, fibromyalgia, for example. And again, I'm not going into the whole controversial topic of even fibromyalgia as a diagnostic label or not. Forward the point that those people can have, like a systemic issue and all the overlapping conditions we talked about. How about IBS, right? And then there's a huge overlap. So the more systemic, there is a generalized inflammation in the body, which in turn sort of underlying, but you want to be aware of it. But more specific to the jaw joint would be rheumatoid arthritis. There
Okay.
can also be genetic factors. So people with, for example, Ehlers-Danlos syndrome, people with joint hypermobility syndrome, might be asymptomatic, but a lot of them do get issues with the jaw pain when there is a lot of subluxations and when there is a lot of clicking, locking of their jaw. And as I said, about 30% of this can be asymptomatic, but when it's symptomatic, then you want to go into the history and just be more aware of your environment and your situation of the person with whom you're dealing with. There can also be degenerative changes in the jaw joint. So, for example, with osteoarthritis, right? So that's something which we deal with in the other joints. The other thing which I wanted to mention, it's a sort of a less commonly known thing, is infections of the ear. So, for example, we have when you're in childhood and when you get a lot of infections of the inner ear, that can actually affect your temporomandibular joint, okay, because of the connection, there's an anatomical link between them. And when you have repeated infections, you'd be surprised to know that it can actually lead to, it's a very, very rare, but it is a serious and a severe condition, is it leads to ankylosis of the TMD,
Oh,
which is something which needs to be detected. Just be aware of it, like just be aware of all these conditions. You also want to know if there's any history of surgery, history of radiation, any head and neck surgeries, So TMD is just not something which occurs on its own. You got to find the cause for it. And broadly speaking, these are all the different causes, which you want to just be aware when you're questioning them in the history.
right.
So you can just see how broad it is. It's just not about pain. You
Yeah.
want to slowly start diverging, and so you just start to notice different symptoms associated with it.
Right. So at this point, I think I want to go ahead and ask you what are conditions or red flags specifically that could mimic TMJ? What are some of those that a physio should be aware of?
Yeah, it's a very good question. Very important to know this. Before I answer that question, you got to know that TMD is a subset of orofacial pain.
Hmm.
Okay. So orofacial pain refers to pain in the cranial, mandibular, and facial structures, including the inner ear and cheeks and the whole throat and everything. So it was a term coined in the late 1980s, or I think early 1980s, by the American Academy of Orofacial Pain. So TMD is a subset of it. So there are a lot of conditions which can mimic TMD or cause TMD like symptoms, but you want to be aware of those things. And one of the few things are dental conditions, which I think we know about it. When patients present with tooth pain or with any infections or with the gingivitis or periodontitis, like something which affects the gums, but which is causing pain. I think that's you might know, and a lot of symptoms are going to be again, if you go back to the subjective history, it'll be sort of a dull, acute, or constant. It would be electric or systemic signs, like they're going to have fever, weight loss, chills, like so with the history itself, you might get an idea that it's probably not musculoskeletal related. So there are a lot of dental causes for the pain. You want to start looking at tumors. For
Okay.
example, we have a condition known as acoustic neuroma, which might cause hearing loss and pressure in the head, headaches, and issues with balance and so on. So you want to be aware of that. So it can be due to an infection. How about septic arthritis, for example? Some people can have an infection of their lymph nodes, right, which can cause swelling under their jaws or like in the cheeks and stuff. Any infection of the salivary glands, which will present with that. You also want to rule out ulcers. It might look something like silly, but if you do an internal cheek screen, you're going to find some ulcers or any carcinomas inside, the buccal tissues, which can mimic a TMD. The other huge one, because of the significant overlap with TMDs, is headaches. You want to rule out if it's a cluster headache, for example, or any headaches which are secondary, and again due to infections like meningitis. We have a condition which is known as temporal arteritis. I don't think they call it like that anymore. It's called giant cell arteritis, where there is an issue with the superficial temporal artery, which is distended over here, and people present with a lot of headaches and jaw claudication. They sort of start using their jaw and it starts to pain. Commonly found in women more than 50 years of age with polymyalgia rheumatica. And so those conditions can mimic, and it's actually a red flag. Like they are in the danger of losing their eyesight, and you want to refer them immediately their general physician and the doctor for further examination. So those are all some conditions you just want to be aware of. Broadly, infections, tumor, trauma, any
Right.
orofacial conditions other than the joint itself, like with the teeth, with the lymph nodes. You also have neuropathic conditions. Now, it's not exactly a red flag because people, if physios, we can still treat it. And classic is trigeminal neuralgia. So we have heard of it, where there's sharp electric pain in the face, worsened by cold or heat. And as physios, we don't fix trigeminal neuralgia. We can just sort of symptomatically manage them and educate them on it. So that is one. So we also have something known as Eagle syndrome,
Mhm.
where we don't fix the condition. It's due to a abnormally long, elongated styloid process, which starts pushing on your carotids, and people have syncope, pre-syncope events. but also with, other issues with, like the pain in and around, the jaw. You just want to be more aware of those conditions, like just know where your limits are. There are certain red flags where you need to send them straight back to the doctor. As I mentioned, tumors, you want to be aware of it, but there are some certain conditions we can help them manage the pain symptomatically. We are not fixing them, like trigeminal neuralgia, or even conditions like, I don't know if you've heard, there's a condition known as hypoglossal neuropathy, which comes due to an involvement of the hypoglossal nerve, and it can happen at the level of your C1 area. And so you just want to be aware of these conditions, which can mimic TMD.
Okay. Now that a patient has come in, and let's say that we've done the stage one of screening for red
Mhm.
flags and we've ruled out red flags, what happens next?
So once the red flags are ruled out, you also want to look for yellow flags in a patient. Basically, any psychosocial issues or any factors which could be influencing their pain processing. A lot of patients with TMD, so I would simply separate this into two processes. One is you have a bottom to a top approach, right? So that's where we are physically examining the joint and,
Correct.
we're checking the joint and doing things. You also have top to a bottom approach. So that's where things like stress, anxiety, depression play a huge role, because all of these increases the threat response in the body. And think about it. What are the first muscles which protect us? It's going to be your traps and your jaws, which increases the tension. So that is something you want to start screening patients for. You want to start screening them for parafunctional habits. Like, why do they do it? Like, what is the underlying cause and how we can manage it? Because a lot of us have stress in our lives. One's having an easy time out. So I think that's one of the reasons why we need to start understanding why this is happening and sort of going towards that role. Why they are clenching, for example. Is it compensatory mechanism? Is it a sudden life event which they're happening? Did someone pass away? Are they going through a divorce? Are they a single dad or a single mom with two kids, managing the household, work stress? So it probably everything is fine, but the environment, the household they are living in might not be fine. And so, so a lot of things, financial stress is huge. A lot of people go through emotional pain. And again, emotional pain can manifest in different ways, which can also cause physical pain. So a lot of things, factors, which you want to take into consideration when you are dealing with the yellow flags. History of abuse, for example. It could be sexual, non-sexual, physical abuse, emotional abuse. So all these manifests in clenching, and because people are looking for some mechanism to deal with, and they often choose to deal it this way. So once you consider that, that's when you want to start slowly pushing towards managing patients. So that's
Right.
where our role comes into play.
Right. So, I mean, when you talk about management, because there's a lot of other conditions that TMJ and orofacial pain mimic, I'm guessing that physiotherapists are not the first ones that the patient will approach, or there might not even be awareness that the pain is due to a underlying TMD or related issue. So, what happens in that case where either due to lack of awareness or psychosomatic factors, patients do not approach a physiotherapist and treatment is delayed or not sought after at all?
Excellent question. So, Srividya, it's actually not only common in India, but even in the United States and Canada here. So, in North America as a whole, only 35% of the people actually come and see treatment. And like even they are aware that that there is something for this exists with physiotherapists. So the stats are quite low over there. The natural history, if you look at it, say, so for example, if you don't treat it and if you just leave it, most studies state that it doesn't go away on its own. It sort of sticks around, it fluctuates. You might have phases of relapse and, like remitting phases where on and off, but it doesn't go away. And also, they have shown that skilled treatments causes improvements in function, leads to better outcomes. So that's we have that a lot of articles stating that as well. It's all bolstered towards supporting physio, and I think it's actually our duty as physios to go and educate the general public about it. that this is something which we can offer. And as you mentioned, like when people suffer from TMDs, often they're not even aware that it's a TMD, first of all, and they don't even think of physios, whereas we have a huge role to play. And you'd be surprised, even I'm sort of deviating a bit from this, but even amongst genders, right, it's almost 3 to 5 times more prevalent in women than men, and especially women of reproductive age. And it affects, don't get me wrong, it affects all ages from children to adults, older adults. But so I think we have a huge, I mean, the onus is on us, to go ahead and educate not only the general public, but also our healthcare professionals. How about our doctors and ENTs and dentists? This is a huge area that if we specialize and if we can get the right treatment, then we can actually help a lot of these patients.
Right. So you are the author of a book on jaw pain, and
Mhm.
your book is extensively about self-management. My question to you is why self-management?
Amazing. So, self management, I would say, is one of the cornerstones of what we should be doing, actually. We should be more like a coach to the patient. We should be helping them understand what is causing it. Because let's face it, self efficacy has proven to have better outcomes for patients.
Yes.
And it's not only with jaw pain or TMDs, but also with back pain, for example. It's just a cliched example where, I mean, where they say, like rather than catching fish for a patient, teach them how to fish, and they get better outcomes. And my other question is, if the treatment, what you do, the first goal of it should be to make the patient do the same at home. Like you can be like, hey, like I'm doing this simple mobilization procedure on you, but you know what? The great news is I can show you how to do it by yourself at home. Even the simple thing sort of increases the independence of the patient, where they start monitoring their own symptoms. So you just need to sort of guide them, in that direction, and they become more independent, and that leads to better pain outcomes. It sort of reduces the stress response from them. They feel more in control of themselves, and the positive image which they have about their body, where they can self treat. So I think self efficacy is huge, but it's very sad that I see a lot of people wanting to make patients passively dependent on them to come for a massage. And I think this comes from the practice of a very outdated model,
Yeah.
from a biomedical approach where you're fixing someone. We are not fixing anybody. The body's heal on its own. Like we just need to sort of guide them, remove all the contributing factors or minimize them,
Correct.
where patients can help themselves. Right? And I think that should be our job as physios. And again, a lot of manual treatments only have short-term effects, even for temporomandibular joint disorders. So I think it's ridiculous expecting to do like a 20-minute massage and a mobilization on a patient and having them come for 20 sessions so that you can giving them the hope of fixing them, rather than teaching them the same thing and moving on with exercises. So you don't need like 5 people to come and change a light bulb. You can show the patient to change the light bulb on their own in their house. And so yeah, I think self-management is huge. And I just wanted to share a personal story with this. I live in Langley. I had a patient who took a flight all the way from the neighboring province to come and see me, and I was actually shocked, to be honest. She was just referred by a friend of mine, and this was the first thing which popped in my head, what I can show her so she can manage the symptoms and what she could do to help herself. And you'd be so surprised how much we can do in a 45-minute session with a patient. And also, I mean, there's no excuse for us, especially with the tele rehab and other tools available at our disposal.
True.
I think patient empowerment is huge. I think most of the best practices and research is pushing us towards it. So we've moved away from a patient centered care, and our focus should be on a person centered care. You just got to see them as a whole person. And I feel that's why self management is huge. It should be huge in the physio world, not only for jaw pain, but wherever we can have it applicable. That is not to say that we shouldn't be treating them, but I think the context which we set for the patient should be the right context, because patients will believe your words. Your words can harm or heal the patients. So I think we should be very, very, very mindful of our language with them.
Correct. You told us about self management and why it's important. It empowers the patient. Can you give us a glimpse of how do you manage a patient
Mhm.
with a TMD and, in the self-management angle, and what are the other things that you tell them, advise them?
Absolutely. So, as you know, there's no cookie cutter approach because everyone is different. We need to find the exact cause of their TMD. But broadly speaking, we as physios have to move away from very specific diagnostic labels, and we need to move more towards lifestyle medicine. Because I think that's where the whole management strategies come, because almost all of that affects TMD. Education about your stress management, for example, or psychosocial management, about some of the relaxation strategies, what they can use to calm the muscles down, or just in general for the whole body. Right? So that's where our role comes into play. You're looking at their sleep, education about sleep, and education about diet. You are also managing their physical symptoms. And I think we are, as physios, I think we are really good at it because this is what we go for, like in managing the joint, about educating on their posture, about their breathing. So I think it's more about the person as a whole. So we got to move towards that person-centered care and look at lifestyle management rather than just managing a particular diagnostic label. I think it trivializes and just minimizes the whole. It doesn't give us a bird's eye view. I think we miss a lot of things. So as I said, there's no one specific management. For example, when patients have issues with their sleep, I think this is a common question we have all encountered. What type of
Yeah.
pillow you must use. There's no specific evidence for TMD, but there is, for some articles have been published for neck pain, where pillows like feather pillows don't do that great compared to the spring type pillows. Or ones with latex, like, so, or the memory foam, they tend to do a lot better. And also, all these are heterogeneous studies, but there are some studies available that you want to measure the shoulder width, and that's got to be multiplied by one, and that's the height of the pillow. So all these are basic. Again, please don't quote me on this. It depends on patient to patient, and like, so,
Mm.
so these are all things which we need to read about and educate ourselves. And I
Mm.
teach about this in my workshop, which I conduct. Specifically, with regards to temporomandibular disorders, it's actually worse when people lie down on their tummy. So, if you are a
Oh.
prone sleeper, it puts a lot of compressive pressure on your jaw. And studies have repeatedly shown it actually worsens your TMD, but also worsens your conditions like your sleep apnea because you're putting a lot of compression. There's not a lot of movement. When you're lying supine, EMG studies have shown there is actually more muscle activity in your masseter, and you actually brooks and you clench more. So sideline they have found to be relatively less stressful. So which is why it's a broad outline what I'm giving you. But again, you want to start
Right.
educating people on this. Even simple things like, every social media guru is, talking about these things, about avoiding your phones, a couple of hours before sleep, avoiding caffeine, having some dim lights, sometimes using white noise helps. So all those are general instructions which you can give, but physio specific instructions, you also want to be aware of all of that. So that's with regards to sleep. And again, the most common thing which people are going to ask you is, what should I eat? So physios often respond by saying, I'm not a nutritionist. But again, the thing is, there are a lot of advice you can give, a lot of general advice. For example, when a TMD is flared up, would you consider cooking your food more, making it more soft, or
Mm.
steaming your
Okay.
veggies rather than having them hard or raw, or probably breaking them into smaller bites? Your key is not about giving nutrition advice. You're actually giving physical advice, what you can do related to food, which is going to reduce the stress on the joints. Classic example is having something like Greek yogurt, which has a lot of protein. Do you want to combine it with other? It's a beyond the scope of this podcast, but I'm trying to tell you that these are all some advices which physios need to start thinking about. Yes,
Mm.
you're not a nutritionist, but you can coach them on what
Right.
reduces the stress on the joint, and then they'll be very grateful for you, especially with chat gpt and other things nowadays. I mean, the patients have probably done this before they've even come, and they've seen you. So it's important that you educate, like yourself, be aware, of what dietary advice you want to give them when they have in phases of trauma, because it's not going to be forever, right? Because you also want to slowly start introducing other things as range improves or as their pain reduces, right? So you want to address them or advise them on diet, on stress management strategies, and psychosocial strategies are huge. I'll give you an example. Like, all of us know about diaphragmatic breathing. As physios, we have learned about it. Diaphragmatic muscles they have shown to be effective in people with chronic temporomandibular disorders.
Oh,
So that's something, which you wouldn't even associate with. But there lies our treatment, where we can go and help them with some simple breathing strategies by giving them feedback, by keeping their hands on the belly, and a lot of other treatment techniques, but then just asking them to breathe in and out. A lot of ways to activate, a lot of different positions to activate the diaphragm. So I think breathing is huge. And I think it's a less often tool practiced by physios. So it's a very niche area, but you want to start doing all this in your clinical practice with jaw pain. So breathing advice, posture advice, I think most of us give posture advice, but
right,
I think you don't want to go to the other extreme where you absolutely want them to be like a statue keeping. It's impossible. There is no perfect posture. And I think the point we need to drive across is your posture has got to be fluid. We got to keep moving back and forth.
right,
Right. We want to avoid excessive extremes. Now, biomechanically, it is known that a forward head posture, yeah, it does cause a negative strain to your whole upper cervical joints. But you also want to understand this. There are a lot of EMG studies which have shown a co-activation of your neck muscles and your TMD muscles. And yes, posture education is helpful, but you don't want to be too anal about it. You want to keep it fluid, you want to keep it moving.
right,
And it's all about reducing the pressure on the joints, like looking at it from a biopsychosocial perspective. So these are all huge strategies and relaxation strategies. I mean, how many of us have done like a mindfulness relaxation or mindfulness meditation? I think it's a huge area in which physios can help patients. And a lot of tools which are available, for example, autogenic relaxation and other resources. Like you don't need a specific uh, well, you do need someone to guide you through the whole process and stuff, but it's not like, I mean, all these tools are easily accessible for us, and even
right.
there's a lot of apps also which help with these, and it's a lovely way to combine your exercises. And again, exercises. The issue is we again look at it just from the jaw, but I'm just looking at a global exercise perspective because again we know that there's a lot of systemic processing happening in the body. There's a lot of central sensitivity, and I think from a global exercise perspective, it's amazing. Like. So you want to think local with the jaw, you want to think regional with the cervical thoracic spine and the whole shoulder girdle, but you want to sort of think global. How about going for a brisk walk with your spouse and having some
Hmm.
quality time? Get some cardio going to get the benefits of aerobic exercise. So I think we need to start thinking, as I said, we need to stop having a funnel approach and having a more global approach when we do jaw management. CBT is another huge area where physios can, again, you need some training for this, for cognitive behavioral therapy. And I'm not saying that you got to be, I mean, we're not replacing a clinical counselor or a psychologist, but I'm just saying you can refer them to those professionals, right? We can refer patients, we can tell them that, hey, I think this is beyond my pay grade, and I think I'm going to refer you to see these professionals. But why don't we start thinking on these lines?
Hmm.
Right. Every time you feel your jaw pain, what do you feel? How do you feel? What situation causes it to worsen?
Hmm.
What are your thoughts when the pain comes? You want to start targeting or start addressing the fears, concerns, their anxieties related with the jaw. So I think there's a lot of tools which are available at our disposal. Yoga is, for example, like a generalized tool, but it works great because it gives patients their empowerment.
Hmm.
You are in control of your body when you do those poses and you're breathing, but it still works. I mean, people feel great after doing those breathing exercises. I mean, we all know it intuitively. Most of us have done these classes and we feel outcoming great. I think it's on us as physios. Like, we got to take the initiative to sort of, start treating. So these are all zones. And apart from this, there's a lot of exercises. Obviously, as I mentioned, it goes without say. We are exercise experts. And I think we need to own this domain. Then again, the other sad part is how many physios ourselves actually exercise nowadays. How many of us know what it feels to do a deadlift or a squat or a barbell squat, or I could go on. So we are talking of taking patients into those territories where even we don't know what it actually feels like. We're just playing a guess game, but that's the harsh reality. So I think we need to get a little bit more involved. It just takes effort. I think your personal experiences will help with the personal experiences of the patients, because at the end of the day, when a patient comes to us, they are looking for is that connection, therapeutic alliance. Am I making sense to you? That's what they're basically asking us, and they want us to explain the symptoms what they have to them. So exercise is one, and manual treatments. I think we do a lot of this. I think we're great at this. We're very hands on. I think that helps. Electrophysical agents. I think we are very good at this. In school, like we go through most of them. I think we need to move away from those. Don't get me wrong. These passive modalities are like candies. You've got to do the hard work, and then you do use the electrophysical agents as a candy for the patient, and that's sort of when patients love it. And that's the problem because they just want to get the candy. They want to just keep
Yes.
getting some good electrophysical agents, and
Yes.
they're not willing to do the hard work. So I think that's where the cognitive restructuring comes. How we frame the whole situation and the context to the patient matters a lot. So as I said, the management it's not a cookie cutter approach, but there's a lot of
Yes.
food for thought, and we can help them a lot. The same applies, like even if it's not TMD, what if a patient with TMD presents with migraine, for example? So you're not going to treat the migraine, you're not going to manage the symptoms of migraine. Of course, we're going to do it.
Mm.
And all of those patients' common symptoms, they're going to present with upper cervical joint dysfunctions, your C1 to C3, present with reduced deep neck flexor endurance. They're going to present with a lot of tenderness. So the same sleep strategies, the same advice of avoiding the triggering factors apply to them, in addition to the generalized exercise prescription we're going to give them. So I think there's a lot of overlapping conditions which you got to be aware of when you just can't treat one and leave the other. And we also got to be aware that this is not like a hen and the sun story, right? Just because the sun comes out early morning and at the same time the hen comes out, the hen is not the cause for the sun rising, right? It just happens, right? And when it happens, when two conditions coexist together, you want to treat both and you want to address both of them. I think this is broadly how self-management goes. Is you're coaching, you're giving them exercises to do on their own. You check back. If you really need to see them twice a week, you can. But it's just crazy. I don't know how people see patients every day for 7 days straight and expect them the pain to go away. Like I don't think that's best practice, to be honest. And a lot of research again is focusing now on booster sessions. They actually booster sessions are effective. Like touch-in sessions where you meet with the patient, see how they're doing, give some feedback, change a few things, and you
Yes.
send them back home. And the massage which we teach the patients, for example, and if you have a very good support network at home, invite their spouses to the treatment, have the spouses show the treatment to them. All it takes is a little bit of effort, a little bit of advice, and it's quite fulfilling, when patients are able to manage. They start identifying, what para functions they have. And hey, I didn't even know that I did that, but thanks for pointing it out to me.
Yes.
Those are some things which people have. Yeah, so I think the management has to be broad. Think about it. What is problem solving for
Mm.
patients, right? You want to want them to problem solve themselves. So I've given you an exercise. I mean, what are you going to do if it starts paining? I'm not going to be there with you at home. So you're going to stop the exercise, or do you want to modify the exercise?
Yeah.
Right? So would you want to modify the form? Do you want to change it a little bit and see if it pains lesser? Am I going to pay for it later? Okay, I'm doing the exercise, doing on my third set, and I'm not feeling that great. Then why don't you stop then? And when you do it the next time, maybe monitor. So you got to start monitoring how you're feeling. Right. I think nothing is set in stone. Like we just can't keep doing 15 reps in 3 sets for the rest of our lives. So, we got to start monitoring how's my breathing when I'm loading my joint, or how's my muscle tension? Like, hey, am I doing it correctly? Why is my forehead wrinkling when I'm doing this
Mm.
exercise? Like, why don't you relax your forehead? All these are simple feedbacks which we need to start having the patients do some reflective questioning with exercises so that they can start monitoring. And it's just not for the jaw, it's for the neck, it's for your almost any condition.
I think I want to ask you if a physio wants to, look at this and say, okay, this is something that I'm interested in and I want to get into TMJ rehab and, orofacial pain rehab. What would be the course of learning for that physio?
I think the first thing is to start doing some workshop just to get, because I'm not sure how the undergrad or postgrad education it is right now. It's been a while. I'm not sure of the current curriculum, but I think I would do a workshop just more get comfortable touching faces, just asking simple questions, like, hey, I understand you got some stomach pain and some IBS like symptoms of back pain. Like, do you have also TMD symptoms? Is it okay if I have a look at it? And patients will be very grateful. Start touching. See, look at it like this. Your pelvic floor and your TMD, I treat both, but these are the two areas in our body which probably our spouses and us have touched the most. Like, no one's going to come and touch your face apart from your dentist. So think about it as a physio when you're approaching someone's face or lips or close to these joints over here. It's not an area which no one's comfortable touching. So the first step is getting comfortable. You want to practice on your colleagues. Try getting some mentorship in India. Try seeing if you can do some online courses. Just getting used to it. You got to get, because unless you get in the water, you're not going to learn to swim. Is my motto. So you want to get in over there. Connect with your dentists.
Right.
Right, you want to see if they can refer patients to you. You actually got to get into the ring. You got to get into the field to start treating patients, and you got to start touching them more. These are areas, as I said, as physios, we are not. I mean, it's a highly specialized area, and as I said, even patients. I mean, like we ourselves. I mean, just a personal experience. It's not an area we touch. Allow people to touch. So, but you got to practice to know even where things are and to start clinically reasoning. I
Right.
think that'll be a great place to start first and get some
Yeah.
mentorship. Problem solve every patient, don't have a cookie cutter approach because every patient is different and the causes are different. So you want to just, go back, do some reflective questioning, reflective thinking as physios, like, hey, I don't think that session went really great. Or, what can I do next session? Like the patient might be happy because you massage them, right? So that's like our comfort food, like our comfort treatment we give them. So, but you want to get a little bit deeper, maybe I could have done this, maybe I could have asked them this question. Hey, by the way, I had a look at their mouth. Do they smoke? Do they have tobacco? You want to slowly start going into those things. Do they drink a lot of caffeine? Are they sympathetic stimulants which can probably worsen any pain processing? You want to start thinking in a different way to approach. And this happens only with reflective questioning, right? You want to go back, you got to sit with your thoughts and see how else you can deal with them. And it's exhausting to do it for each and every patient. So my advice is just start with one.
Yes.
Do it like a case analysis, think about it, delve into it. That's when you start sort of developing some thoughts about it and try it and discuss with your colleagues, rather than you yourself doing it. I
Yes.
love the saying by the Buddha, like he said, with one candle you can light 1,000 other candles or something, and then, but the candle like it does not lose its light,
Yes.
right? So share with others, talk with your colleagues and friends, network a lot. I think you just got to put yourself out and just reach out and ask them. Start reading some research papers, once in a while. Coming back to YouTube, because as I said, it was the Wild West when I was growing up, and now it's like almost people show it. I mean, people want to show it in reels and shorts, and obviously we have a lot of crap in this, but it gives you some access, right? You want to talk with people. At least there's a media where you can engage with people. Right or wrong is secondary, but there is a scope, there is a space where you can engage with people, which I didn't have when I was growing up. So I think that's what I would suggest. Just to put yourself out there, see what it goes. It's not different than treating any other joint.
Yeah.
How different is it treating than your shoulder or your knees? I mean, it's the same subjective history we take. It's the same principles which we use. I think people feel overwhelmed when they hear about it. But I think the more you start treating it, I think you get more comfortable in it. I think you got to be a student throughout your life. I think that's the thing which physios need to know, that things keep changing. What was 20 years back is not now. And I think you can't be dogmatic in your approach thinking this is it.
Yeah.
This is just this one book and I've mastered everything. It's never that way. I think the attitude has to change. You really need to sort of bow down and, have a little bit of gratitude to that, this profession where, okay, I'm here. It's given me a lot, but I think this is
Right.
not the end. So it's
Right.
definitely not the end. And you know
Yeah.
what we are talking today, things might change the next 30, 40, 50 years. I mean, who knows?
Yeah.
But the only effort we can put in is to just make sure, give our best effort in this moment at this stage.
True. True.
And
Thank you for doing this with us because this has been extremely insightful, and I hope that this will serve as an inspiration for many to take up this field and go ahead and do it in the way that it should be done. And also, I hope that it serves as some amount of awareness to the general public to know that yes, physios play a role in TMJ. All these symptoms that I'm experiencing could be part of my TMD and orofacial pain, and maybe this is something that I can take to a physiotherapist, and a physiotherapist will help me out. So I hope that this podcast does these things to both students and to the people who are suffering from pain. So thank you for your time, Sid. This was
uh,
really great.
Thank you so much for having me at your show, Srividya. It was actually a pleasure chatting with you. I hope whatever little knowledge I've gained, I'm just happy to share.
Yes, yes, of course.